Welcome to Salvage Saturdays, the series where we explore the science, surgery, technology, and strategies dedicated to the one mission, which is to save limbs. Today's episode, we're going to discover and discuss. It sounds very futuristic, but also fascinating conversations in modern wound healing. And we're going to talk about using sound waves to heal our diabetic foot ulcers. I'm pretty sure I dabbled a little bit in an episode about this, but we're going to go dive more into it. So we're mostly going to be talking about extracorporeal shockwave therapy, but it's actually one of very exciting emerging regenerative technologies in limb salvage medicine. So hopefully by the end of this episode, you may never think of sound the same way again when it comes to wound healing. So, the history of shockwave therapy. The story of shockwave therapy begins far away from diabetic wounds, of course. It began with underwater explosions, military physics, aerospace engineering, and kidney stones. And then in the mid 20th century, physicists studied underwater acoustics and noticed something extraordinary. When high energy pressure waves moved rapidly through fluid, they generated immense mechanical force. What's that not crab, what's his name? What is it? It's like a shrimp. What's that shrimp name? I'm going to have to Google it right now. The shrimp sound waves. It's because I've seen it. The pistol shrimp. Yeah. Anybody ever seen the pistol shrimp? Because any anywhere that pistol shrimp blows his little claws or whatever, if it I think it's its mouth, but wherever it goes, and if it's directed to an animal, that animal just like goes dead, like because it's supersonic. But think about that doing to bacteria, right? It's like the pistol shrimp to bacteria. So, like I said, the high pressure waves moved through the fluid and generated immense mechanical force. And these waves could transfer energy, fracture materials, create cavitations, and disrupt structures at a distance. But later, researchers studied that supersonic flight and they discovered that shock waves generated by aircrafts could damage nearby structures. Hmm, that's what we want, right? A little bit. So scientists became fascinated by the power of acoustic energy, and this became a groundbreaking medical idea. So, the birth of lithotripsy. So, in 1970, German researchers began investigating whether focused shock waves could break apart kidney stones without surgery. And this led to the development of the extracorporeal shock wave lithotripsy. So this was the first successful human treatment that occurred in 1980. So that's quite recent, and it happened in Germany. So it was this machine generated high energy acoustic waves outside of the body, and they focused precisely on the kidney stones. I believe everybody's kind of familiar with that when it comes to breaking kidney stones, right? And the stones were shattered, and medicine changed forever. But something unexpected happened. So researchers noticed that the tissue surrounding the treated area often demonstrated increased vascularity, improved healing, and enhanced tissue responses. So instead of causing pure destruction, a certain energy level actually stimulated repair, and that observation changed the direction of regenerative medicine forever. So, how did we get shock wave therapy that into orthopedics? So, in 1990, still very recent, orthopedic physicians began experimenting with low energy shock waves, and they discovered that it improved tendon healing. Because I remember in podiatry school and residence, they do it for plantar fasciitis. That's where I first learned the word extracorporeal shockwave therapy. They also used it for non-union fractures, plantar fasciitis, like I just mentioned, Achilles tendinopathy, calcific shoulder disease, and chronic pain syndrome. And researchers started asking if acoustic waves can stimulate tissue regeneration in the tendons and bones, could they help chronic wounds? And the answer is probably yes. So this is how they led to researching extracorporeal shockwave therapy in wound care and diabetic limb salvage. So, what exactly is extracorporeal shockwave therapy? Extracorporeal shockwave therapy is the application of high pressure acoustic waves into tissue. So, extracorporeal means it's outside the body. So, the device generates mechanical pressure pulses that travel through the tissue. These are not electrical shocks, this is not ultrasound imaging, these are mechanical acoustic energy. So, what makes shockwave different? So, true shockwave has a very rapid rise in pressure, high peak energy, short duration, and followed by negative pressure. And this creates compression forces, tension forces, cavitation effects, mechanical stimulation. And the body interprets these microscopic mechanical stresses as biological signals. And this process is called mechanotransduction. So, what is mechanotransduction? Mechanotransduction means converting mechanical force into cellular energy. So, cells are not passive. Cells actually respond to pressure, tension, stress, no, yeah, stretch, vibration, and fluid movement. And shock waves stimulate fibroblasts. That's what we want, endothelial cells, stem cells, inflammatory mediators, and extracellular matrix signaling. And the tissue generally receives this wake up call, right? So, how does extracorporeal shockwave therapy stimulates healing? So, this is where it becomes a little fascinating. Well, actually, I think true fascinating. All you have to say is for me to be so interested into a new technology or a new treatment, say angiogenesis and fibroblast generation. I'm like, my ears are perked up and I'm ready for it. I'm ready to listen. So, one of the things that it does is angiogenesis. So, one of the most important effects of extracorporeal shockwave therapy is angiogenesis. And that means what? The formation of new blood cells. So, this is quite massive in our diabetic limb salvage arena because why? Diabetic wounds are very affected by microvascular disease, ischemia, hypoxia, and poor perfusion. And without oxygen and blood flow, these wounds cannot heal. That's why I say vascular, 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 right? Say it 3 times. And shockwave stimulates the release of VEGF, okay, endothelial nitric oxide synthetase, nitric oxide by itself, and vascular growth signaling molecules. And what does that cause? This promotes capillary budding, endothelial proliferation, microvascular formation, and improved perfusion. And in simple terms, extracorporeal shock wave therapy helps the body grow new circulation, and that's what I want. So, another thing that extracorporeal shockwave therapy helps with is collagen remodeling. So, the collagen remodeling is helped or done by when shockwave therapy stimulate the fibroblast activity. We already know fibroblasts produce collagen, right? And in chronic diabetic foot ulcers, our collagen becomes weak, disorganized, and degraded. So extracorporeal shockwave therapy promotes the collagen synthesis, the collagen alignment, the extracellular matrix modeling, and this will help improve the tensile strength of the collagen, the granulation tissue quality, the wound stability, and tissue integrity. That's why I'm always like tell people quality over quantity because you can rush a wound, but it will reopen very fast if you rush it. Like if it's not ready to fully close. I remember one time the wound was in right there. It's like almost right there. The edges are right there. And yeah, mm, it it wanted to close when it was ready, but it finally did. But another thing that extracorporeal shockwave therapy helps with is stem cell activation. So emerging evidence suggests that extracorporeal shockwave therapy may recruit mesenchymal stem cells, progenitor cells, and regenerative signaling pathways. And this can help shift wounds out of the chronic inflammatory stage. And that's what we want, right? That chronic inflammatory stage arrest and back into the active healing. Like we want you into the proliferative stage. That's where I want my wound to be, okay? Proliferative. And then once you finally heal, remodeling. Let's do this, right? But when you're in that stage where you're finally actively healing, your body and it's closing slowly, right? Your body is actually in two phases at the same time. The parts that are already healed, they're in that remodeling phase, and the parts that are trying to close are in that proliferative stage. So, so two things are happening at once when you're in that active healing phase. It's beautiful. So, some regenerative specialists now call extracorporeal shockwave therapy mechanical regenerative medicine. Now, another thing that they have noticed effects with extracorporeal shockwave therapy in diabetic ulcers, they've noticed that it has some anti inflammatory effects. So, as we know, our chronic diabetic foot ulcers become trapped in that prolonged inflammatory phase, right? And shockwave therapies appear to modulate the inflammatory cytokines and reduce the inflammatory stagnation. And this can help the wound transition into the proliferative phase of wound healing. That's what I want. I'm like, go there, please. Just get there. Now, another thing is it improves the microcirculation, but I think that kind of goes hand in hand with the angiogenesis. But extracorporeal shockwave therapy improves tissue oxygenation, capillary blood flow, microvascular perfusion, and some studies have demonstrated improvement in the transcutaneous oxygen pressure. So this is extremely important in our diabetic ischemic wounds, right? So there are actually types of shockwave therapy. Not all shockwaves are the same. So there are two major categories. They have focused extracorporeal shockwave therapy and radial shockwave therapy, right? Extracorporeal shockwave therapy. So focused extracorporeal shockwave therapy, this one penetrates deeper, converges at a focal point, generates higher concentration. This is what I would want. It's commonly used for orthopedic conditions, bone healing, chronic wounds, diabetic ulcers. Focused extracorporeal shockwave therapy is the most studied form in diabetic foot ulcer research when it comes to extra shockwave therapy, right? The radial extracorporeal shockwave therapy, this one disperse outwards, is more superficial and have a lower peak energy. And they're often used for things like plantar fasciitis, soft tissue pain, muscular disorders. Some wound centers do use radial extracorporeal shockwave therapy, but the evidence for diabetic ulcers is stronger for with the focused type of extracorporeal shockwave therapy. Now, energy levels and frequencies. So this is where some we can get confused because the protocols actually vary, and this is something you have to actually know as a wound care specialist. These different types of energies and frequencies because it does play a role. And remember, electricity and all this jazz. It's actually quite complex. I remember when I was like learning this, and I'm like trying to understand it because it's like a little bit of physics. So there are variables when it comes to energy levels and frequency with the extracorporeal shockwave therapy. So the important variables are the energy flux density, the pulse frequency, the number of impulses, the treatment intervals, and the treatment duration. So low energy extracorporeal shockwave therapy typically is zero point zero 0.03 to zero point 0.1 mj per mm square. Okay. So most diabetic ulcer protocols use low energy settings because why? It's safer, less pain, and more regenerative than destructive. Now, medium energy is zero point 0.1 to zero point 0.2 mj per square. This produces stronger biological stimulation. It's used very selectively. Now, high energy is above zero point 0.2 mj per squared. This is more painful, more common in orthopedic applications, usually avoided in fragile diabetic ulcers. So, what are the common frequencies that we use in our diabetic foot ulcer protocols? So, they usually do the frequency per session is 1 to 3 times weekly. Usually it's 100 to 500, 100 to 500 shocks per centimeter square. And duration of treatment would be like 4 to 10 weeks. Okay. Some systems use 3 hertz, some systems use 5 hertz, some systems use 10 hertz, some systems use 15 hertz frequencies. Higher frequencies deliver pulses faster. Lower frequencies may allow deeper tissue recovery between the pulses. There is still no universal standardized protocol for this. So, how long should extracorporeal shockwave therapy be used? Most clinicians reassess every 2 weeks. Okay, that's how you should. Common total treatment durations is 4, 6, 8 weeks. We'll see what your insurance approves. Also, that because that plays a role too. Some wounds show improvement within 2 to 3 sessions. Other require prolonged treatment depending on the ischemia, the infection, the offloading, the glucose control, and the wound chronicity. So, how can extracorporeal shockwave therapy help our diabetic foot ulcers? So, like we said, our diabetic foot ulcers often biologically become stuck. So, instead of progressing normally through a normal healing phase, they remain trapped in the chronic inflammatory phase. And common diabetic wound problems, as we all know, is impaired angiogenesis, neuropathy, ischemia, chronic pressure, abnormal collagen, poor immune function, oxidative stress, bacterial colonization, and biofilm formation. So, extracorporeal shockwave therapy attempts to biologically restart healing. So, what happens after treatment? So, after extracorporeal shockwave therapy, a lot of clinicians observe increased granulation tissue, healthier wound beds, improved epithelial migration, decreased slough, better tissue oxygenation, and wound contraction. And some wounds actually remain stagnant for months and then suddenly begin progressing. So, does extracorporeal shockwave therapy replace standard wound care? Absolutely not. Okay, that's a simple answer. Absolutely not. And that's critical. Extracorporeal shock wave therapy should be an adjunctive therapy. It's adjunctive. Okay, so you still need to do debridement. You still need to do infection control. You still need to do offloading. You still need to do glucose optimization. You still need vascular no matter what. You still need moisture balance. You still need pressure redistribution. You still need nutrition optimization. No technology can overcome uncontrolled biomechanics. Okay. So, what are the indications for extracorporeal shockwave therapy? Potential indications include chronic diabetic foot ulcers, neuropathic ulcers, delayed wound healing, pressure injuries, venous ulcers, disorders, musculoskeletal injuries, and chronic inflammatory tissue disorders. And some centers are now investigating extracorporeal shockwave therapy for ischemic wounds, flap healing, graft incorporation, and post surgical healing. So let's get to the nitty-gritty part. Contraindications, because that's something we all need to know. Because extracorporeal shock wave therapy is not appropriate for every patient. So contraindications for extracorporeal shock wave therapy may include untreated osteomyelitis, active severe infection, exposed large blood vessels, malignancy near the treatment area, unstable necrosis, severe coagulopathy, active hemorrhage, untreated critical limb ischemia. These are absolute contraindications. And then also, I would say absolute, but they have to use with caution and clearance when it comes to implanted pacemakers. I wouldn't use it on a patient who has one. I'm just saying for myself. Severe neuropathic pain syndrome, pregnancy, yeah, I wouldn't do that. Pediatric growth plates, I wouldn't do that either. I wouldn't bother those areas. I would just leave that alone. So, what happens to the patient? What's the patient's experience? Patients often feel a tapping sensation, a rhythmic knocking, vibration, and a pulsing pressure. Some discomfort does occur. Most treatment lasts for 5 to 20 minutes, usually outpatient, and most patients tolerate it well without anesthesia. So, what does the latest research say about that? Research on extracorporeal shockwave therapy in diabetic wounds has accelerated significantly. Several pooled analysis and systemic reviews now suggest promising outcomes. A major pool analysis found that diabetic foot ulcers treated with extracorporeal shockwave therapy were significantly more likely to heal when added to the standardized wound care. So researchers observed improved complete healing rates, reduced wound size, enhanced tissue oxygenation, and favorable safety outcomes. And other studies have demonstrated increased granulation tissue formation, faster epithelialization, and shorter healing times. And some analysis have suggested that the wounds may heal several weeks faster than standard care alone. But there is a problem. You have to remember that research quality does still vary. So current limitations include small sample sizes in these research studies, inconsistent protocols, different machines, varying energy settings, variable wound severities, as well as lack of long term follow up. So, while extracorporeal shockwave therapy is extremely promising, they need more large multi center trials are needed. Okay. So, what is the future of extracorporeal shockwave therapy? Future will be, I believe they're going to combine it with stem cells, PRP, skin substitutes, oxygen therapy, AI guided wound mapping, regenerative scaffolds, and bioengineered tissue. Some researchers believe that extracorporeal shockwave therapy could become a central pillar of regenerative limb preservation medicine. So let's do a quick case study. 62-year-old male with type 2 diabetes, peripheral neuropathy, hypertension, and mild peripheral arterial disease. Hemoglobin A1C is 9. Chronic plantar ulcer beneath the first med head presents for 7 months. Previous failed treatments are collagen dressings, topical antimicrobials, standardized offloading, and local wound care. The wound size is 3.1 by 2.0. No active osteomyelitis, moderate granulation tissue present. So, what is our treatment plan for him? The patient underwent focused extracorporeal shockwave therapy, low energy protocol, once weekly treatment, 250 shocks per centimeter square, total of 6 weeks. Additional treatment management included aggressive offloading, sharp debridement, glucose optimization, and moisture balance dressing. So results are within 2 weeks, there was a healthier wound base, less slough, improved granulation. Week 4, wound contraction, visible epithelial edge migration improved, and drainage reduced. Week 6, wound area reduced nearly 60%. Week 12, complete epithelial closure achieved, no adverse complications occurred. So, our final thoughts are that shockwave therapy represents a remarkable shift in medicine. For decades, we viewed chronic diabetic ulcers primarily through and treating it through dressing, surgery, antibiotics, and pressure relief. But now we're entering this era of regenerative mechanobiology. So they're using physics to help stimulate healing, using acoustic energy to activate dormant biological pathways. They're using sound to preserve limbs, and extracorporeal shockwave therapy is not magic. Does not replace vascular care, does not replace offloading, doesn't replace debridement, doesn't replace infection management and control, doesn't replace biomechanics. But it is good to have something as a adjunctive therapy because there's a new adjunctive therapy in modern limb salvage because sometimes healing does not require another drug. Sometimes healing the body simply needs the right signal, and shock waves can be that signal that they might need. Okay. So, this was another episode of Diabetic Fit Files. Welcome to Salvage Saturdays. And if you enjoyed this episode, make sure to share it with a clinician, a podiatrist, a wound care specialist, or anyone who cares about limb preservation because every wound has a story, every limb deserves a chance. And I'm Dr. G. This is Diabetic Foot Files. Take care of your feet because they take care of you.